Okay. Good morning, good afternoon, and good evening to everybody. Welcome to today's APMEN Tech Talk hosted by the Vivax Working Group. I'm Dr. Caroline Lynch, Regional Representative for Medicines for Malaria Venture and co-chair of the APMEN Vivax Working Group. We're very happy to have this webinar today on expanding pediatric antimalarial treatment. And I'll just go through some of the ground rules, the webinar format for you all, in case you're new to the Tech Talks. We'll have the videos of the panelists, and as those presentations are being made, please feel free to make comments in the chat box. But if you have questions, please put them in the Q&A box, and some of the panelists will answer those in writing during the presentations, and some will be answered afterwards during the discussion. You can upvote different questions by clicking on the thumbs up icon instead of repeating a question if there's one of interest to you. And then at the end of the webinar, we'll have a quick Zoom poll just to check and see how you found it. So with that said, I want to introduce our excellent panelists. We have Professor Ernie Nelwan, who is the head of the Division of Tropical Infectious Disease at the University of Indonesia. Professor Ernie is also on the National Expert Commission for the National Malaria Programme. She's a professor of internal medicine and tropical infectious disease, and she serves as a clinician, researcher, and lecturer at Cipto Mangunkusumo Hospital. She's widely recognised for her leadership in infectious disease research, antibiotic stewardship, and national health policy. We also have Dr. Andre-Marie Tretu. He's a Senior Director for Medical Affairs from Medicines for Malaria Venture in Switzerland. He leads efforts to improve access of high-quality antimalarial medicines in endemic countries, and he draws on his experience as a clinician and public health professional, initially trained in Burundi, has worked with MSF, Sanofi, throughout a lot of countries in Africa, and he continues to build his expertise through advanced training in international health management. We also have Dr. Briony Moore. She's a clinical pharmacologist, pharmacology researcher, especially in infectious diseases, with a strong focus on antimalarial pharmacology. She completed her degree and PhD at Curtin University, has worked at the University of Western Australia, and she leads collaborative malaria research trials in Papua New Guinea. She is a senior research fellow and program lead for infectious disease clinical pharmacology at Curtin Health Innovation Research Institute. So these are excellent panelists we have with us today to talk about expanding pediatric antimalarial treatment. Before Professor Ernie starts, what I want to highlight is that in the last few years, WHO have brought out a lot of revised recommendations, not just on Vivax malaria, but also on falciparum malaria. Some have gone under the radar, some have got a lot of attention, some have gone under the radar. One key one that we wanted to highlight was especially around pediatric care. For example, breastfeeding women who are breastfeeding kids over a month old can now take Primaquine if the child has had a G6PD test. Additionally, there have been new formulations of antimalarials have come out that Andre-Marie will talk to, such as Coartem Baby for 2 to 5 kilo babies, and low-dose Primaquine for children, treatment of Vivax in children, but also for transmission blocking in younger age groups as well. So just to highlight that there have been and are changes going on in this space to expand pediatric antimalarial treatment, and hopefully the discussions today will raise awareness around that and get people a bit more interested in this space as well to ensure equitable access. So with that, I'll stop talking and I'll hand the floor to Professor Ernie.
Yes, thank you, Caroline, for the time. Hello, everyone. I'm happy to be here and share the slides on. Yeah, regarding the treatment of malaria in pediatric and of course also in adult in Indonesia. And I would like to share the updates in malaria treatment and current challenges that we have. As mentioned, I talk here on behalf of Indonesia Malaria Working Group. So this is actually, I would like to start my presentation with the optimism that this is the picture that we want to have, and Indonesia aims to eliminate malaria by 2030. We are the country with around more than 274 million residents that's located in quite a lot of different islands, and this is, of course, will give the challenges to goes to the elimination phase, and we are now in 2026. So this is the actual situation of malaria in Indonesia at the moment. We have still struggling with the eastern part of the country that, as you can see here, with a quite high endemicity. And there's also the area that almost reached elimination in the color of green. So this is the situation. And then also recently, actually, we also have problem with the re-establishment of malaria, that cases reported from the area that already been eliminated or declared as zero cases. Sorry. Yeah. So this slide show you that the number or the proportion of malaria based on the age is actually decreasing on the age of less than 5 years of age. And then the proportion of the productive age that reported of getting malaria is increasing. And as you also aware that in Indonesia, we have 5 species of Plasmodium with the high rank of Falciparum, followed by the Vivax malaria, and then recently there's the non-human malaria known as Plasmodium knowlesi is also reported in scare area of the country. So then this is actually another challenges that we have, because of we are still struggling with the quite serious one, the Plasmodium falciparum, and then we are also facing the most difficult to treat one because of the chance of relapsing with the Plasmodium vivax, and then the last one is the challenges in diagnosis with the Plasmodium knowlesi. But you can see in the right side chart here that actually the number of the reported cases is decreasing through years, but now Indonesia is facing the stagnant phase of eliminating malaria. So all the data that I've been shown to you is at the moment can be timely addressed or reached by the system that we call the malaria reporting systems, that this actually will help the government to monitor and take appropriate action if there is any alarming report through the to this existing program. So as we know that for malaria, it is not only talking about the burdens, and then the burden is actually not in all over the country for Indonesia, in particular in certain area, but because of the mobilization of the people, then even though in the non-endemic area, we still need to be aware of the potential occurrence of the infection, and also the diagnostic challenges that I'm not going to address a lot in this talk. I'm going to goes directly to the malaria treatment in Indonesia, since recently we introduced the optimization for the radical cure of malaria treatment. So Indonesia government adopt the WHO recommendation for malaria since 2004. We are no longer using chloroquine as our standard national treatment program. We moved to the artemisinin combination-based treatment in combination with primaquine. So we have the physician because as you understand, in the area, in the remote area where they are lacking of capacity to consult it or to make the proper diagnosis, then physician on the fields needs the things to be able to make the proper diagnosis in time. So we have these pocket books that help the physician to give or to do the approach treatment, diagnostic and treatment correctly. And all of this is supported by the regulation by the Ministry of Health. So we are using the dehydroartemisinin in piperacin as the ACT in combination with primaquine. We no longer using the chloroquine, and just recently we have the formulation of dispersible dehydroartemisinin in piperacin for children to ensure the proper dosage due to the difficulty of getting correct dosage by crushing the drugs that we usually have. But unfortunately for primaquine, we still do not have the similar option. So for the treatment, we give the dosage of falciparum as written there. The recommendation is the low dose of primaquine for 5x treatment as a standard treatment in Indonesia. So then the question is, of course, we do not have much option to give higher doses of primaquine, and then we want to learn and to see whether this 14 day of primaquine is actually could work or can be adhere to the patient. So this is the study that conducted in Papua, showing that by do the oral supervision of 14 days primaquine is actually can give the good adherence. But of course, this might not be easy to do because of we might not have enough human resources to see all the patients that been given the medicine to be adhered to the treatment. So still the answer that if it still work, but we need to have a better option. So then this is another study they conducted in another area of Indonesia. This is conducted in Sumatra, effort study looking at the 7 days of primaquine, higher doses of primaquine in comparison to the 14 days of primaquine considered as a low dose, and to see how this can be actually improve the efficacy and also of course safety to the patient. And this study is actually showed that given 7 days of primaquine from the effort study give a well tolerated no safety issue. And then if we can see here in the occurrence of parasitemia and also the symptomatic 5x parasitemia between the 7 days of high dose primaquine, means given 1 milligram per kilogram body weight for 7 days, is less compared to the 14 days of low dose primaquine that been used as the standard treatment in Indonesia. So then this actually telling us in Indonesia on how we can actually improve this. I'm not talking a lot about the tafenoquine because we are not really at that time having the capacity for choosing this tafenoquine as our standard option, but primaquine is already been registered, and optimizing doses might not be that difficult if it's considered, of course, safe. So then we are moving to another study that already been done, and the manuscript is on preparation. They're comparing the highly dosed short course primaquine after, of course, the testing of T6PD test to perform the radical cure of malaria. And this study is conducted in 2 sites in Sumatra and 1 site in Papua. And then the result of the study is already been shared to the Indonesian government, and then resulted to the new recommendation that already been launched in the World Malaria Days in April this year. So this is the important update that I would like to share to you, that the Indonesian government now in the limited setting, in particular in the area where the place is already involved in the scope trial that just been mentioned in the previous slide. We are providing the capacity to do the G6PD testing, and then from that trial, we try to have the classification on how to put patient with the normal G6PD, intermediate, or even deficient to the new recommendation, or what we call optimizing primaquine dosage. We are not really calling the high dose because of the modest cultural reason. So then the patient can receive this new recommendation. And of course, we still have the open opportunity for those that are not really eligible to receive the treatment by using the standard treatment that already been approved before. That's the low dose primaquine for 14 days. So besides of that, of course, that this talk will more see the opportunity to give better treatment to the pediatric. So what we have now in the Indonesian new recommendation is we are providing the dispersible dihydropiperacin tablet that will be easily given to the children. And then also we have the other potential ICT to use using the artemether lumefantrine with the doses that more convenient to choose it for the pediatric, and also the formula of the artesunate in the form of sachet to be used for the children. So this is actually the commitment for us to give the better access for children to be treated in a well-tolerated manner. So this is how we put in our new pocket guideline that we try to help the physician, like already mentioned, so they are not really need to give a lot of calculation. So they just use the body weight, and then they can choose on how many tablets precisely they can be given to the patient. As we are all might aware that the setting of malaria care in the primary health care will be like conducted a lot of testing and might give a lot of positivity diagnosis. So we really need a timely manner to start the medicine or given the prescription to the patient. So then same for the DHP, dispersible, and also for adult, and also for the other option of artemisinin combination treatment. So this is the study protocol that already mentioned, and then the paper is still in preparation, but the study showed that in G6PD normal or intermediate patient, there are no risk of hemolysis that related to the treatment, and then still the efficacy of the recurrence rates lower in the short course treatment compared to the 14 days treatment. So what we are now needed is actually the operational strategy, how to expand these findings to all over the country, or even prioritizing in a certain area of the malaria care. So I would also want to mention that for the treatment for severe malaria, we are now have this option as an artesunate that can be given intramuscularly and intravenously with this dosage, and then all will be followed by the 3 days of oral ACT and primaquine as recommended by the WHO. Okay, my last slide, we'll be talking about the challenges. Of course, for Indonesia government, we are still early in understanding how our new recommendation by optimizing the primaquine doses can be successfully implemented, and also the potential access for the G6PD test through all over the places is also another challenges that we still need to evaluate. Not also to mention the capacity of the laboratory person to do the test. And of course, we are all aware that even though we already give the short course Primaquine, there is still relapse cases reported among this study, among this patient that have been observed. So there's still, of course, the question to all of us whether we really need to again optimize the Primaquine dosage. There's a study conducting about the ultra short course of the high dose Primaquine, and also, of course, how about the other option like tafenoquine study as the treatment for the relapse or the malaria 5X. The challenge for Indonesia, of course, we still need to learn on how the partner drug, as you are all see that we are not using any more chloroquine for the treatment for the schizontosoidal parasite. So then how this will be then effective. There's a study on looking at the optimized dosage of tafenoquine, the TADOR study, the CDOT, that we still wait for the result. And of course, hopefully we still can add more on the pediatric drug formulation, such as the dispersible primaquine or tafenoquine for our patient in Indonesia. I think with that, I will stop talk and I'll give back the time to Dr. Caroline. Thank you very much.
Thank you so much, Professor Ernie. I very much enjoyed that you started your presentation with a note of optimism, given there are challenges and there are gaps with the pediatric formulations available, but I'm buoyed up by the fact that there's so much research and evidence being generated on that. And maybe now to talk about a few of those gaps and how to fill them, I'm going to invite Dr. Andre Marie to give his presentation. And just a reminder to folks, please, if you've got any questions, put them in the Q&A section, and either the panelists will answer them in writing or we'll address them during the discussions.
Yes, thank you, Carrie. Good morning, good afternoon, good evening, everyone. Can you see my slides? Yes.
Yes, they just need to go into this. There we go. Perfect.
Good. Perfect. So thank you, everyone. I'm glad to be part of this APMEN meeting. It's my first one, and I believe first of a long series. So I'll be joining more often now, moving forward. So I'm really glad to be here. So talking about innovations, I think it's clear that the burden of malaria today is highest in children, and for a long period of time, the malaria drug development community has been focusing on formulations that most of the time were not really friendly for children, though this is the highest population affected by this disease. Same applies for pregnant women, though everyone recognizes that pregnant women are most affected by the disease. A drug like lumefantrine, we had to wait for 20 years for the drug to be officially accepted for administration to women during the first trimester of pregnancy. So these are some of the gaps that I think in the drug development we are trying to kind of cover. Most of the ACTs today, they have a child-friendly formulation. Professor Annie just mentioned that. And moving forward, we are trying at MMV to make all the future drugs available in a very child-friendly formulation as well. Just to note that for those who don't know, MMV is a drug development partnership based in Switzerland, but working across the world with several partners to help to help in the research and development of antimalarial product. So this deck will focus mainly on what are the practical innovations, covering some of the gap and improving treatment completion and the outcomes of malaria treatment. So we are aiming to transform malaria outcome in children. And as I said, it's the highest population affected by malaria, and this is across all endemic regions. The adult adapted medicines can create avoidable barriers. So adult product compromises dosing, taste, adherence in diverse community. So children in malaria endemic settings across Africa, Southeast Asia, Latin America, and the Western Pacific, they face formulation and delivery barriers. We have seen, and I am those days on the field, I faced that, having children who cannot take the tablets. So we had to crush the tablets, and definitely administration is often not optimal with this kind of adult formulation. So child-friendly innovation is a program level because these better formulations will definitely improve coverage, improve adherence, and reduce, of course, the negative outcome of treatment. So reducing relapses, reducing and supporting all the malaria elimination efforts that countries are doing across the world. I think the example of tafenoquine that it's very well known in the Asia Pacific region now is here to speak for us with the tafenoquine pediatric formulation that is now developed. So what breaks down when medicines are designed for adults first? It's clear that pediatric formulation matters because they are dosing inaccuracy. Split or crush adult tablet increase under or overdosing risk across various care pathways. The issue is not limited to one geography. I think this is across, this is everywhere. We mentioned the poor adherence. We mentioned the long-term consequences with the repeated episodes and failing of obtaining the radical cure that is expected. And pediatric design, definitely because of these issues, because of the burden, were imperative to address. And tools have been emerging, I think, from the artemether lumefantrine dispersible that was one of the first drug child-friendly formulation developed by MMV. We are now having an entire portfolio with availability of child-friendly formulation for almost all the antimalarial drugs available. Professor Annie mentioned Primaquine, and very recently we got a low-dose Primaquine and child-friendly formulation pre-qualified by WHO. So today it is something that is this is available. Another consideration is weight-based dosing for practical consideration. Weight-based dosing by ranges is very important so that it makes easy administration on the field. And this can generate definitely a community health impact with simplified protocol that make treatment feasible for frontline and community health workers. And all these have been obtained through collaborative development partnerships that have accelerated development and that have accelerated as well deployment in endemic countries, in endemic regions. It is clear that alone is very difficult, but with partnership and collaboratively, we can definitely get where we all want to be. So all these are the model in which MMV and partners are collaborating. So I'll just mention maybe three examples of quite recent innovation. I think we mentioned tafenoquine already. with the single dose potential that today we can have for children as well, with a dispersible formulation that is available and that can close some important treatment gap. Of course, G6PD testing is very essential, remains very essential in this population as well. And beyond Africa, I think this is a solution for PVIVAX relapse burden, as that has been demonstrated in several studies in adults. I think Coartem baby is I'll say the new, completely new case that is as an innovation, and it is addressing one clear gap. This is the first treatment designed for babies for 2 to 5 kilos. Most of the drugs are tested for children beyond this category of weight, though it is very well known that the physiology on the 5 kilos is slightly different from the rest of the infant group. So this is the very first antimalarial that is designed and that is studied for this population. This is creating a sort of subset of population in in infants. So this evidence were built for this fragile population through what we call the Kalina phase 2, phase 3 study. And data were supplemented also through PBPK modeling to support neonatal dosing. So modeling came here as a strong support because availability of real data in this category are sometimes scarce. So the modeling could help. And then this is a regulatory milestone that has enabled access. WHO pre-qualification has been very supportive, and it supports also procurement at national guidelines uptake. And implementation is now something that we are following up so that the uptake of this drug can be ensured. And we are working on this with our partner Novartis, who is the marketing authorization owner for this drug. So, and yet again, AL has been out there for more than 25 years, and we had to wait for all those years to have this specific population getting actually a drug that is tailored for them, and making sure that we can get the full potential of the drug in this specific population. So this set definitely a precedent that needs to be now discussed with other drugs maybe and other levels. Primaquine pediatric, as I was saying, today there is a WHO pre-qualified option for Primaquine, for pediatric Primaquine, 2.5 milligram and 5 milligram dispersible, flavored mask tablet for children slightly under 5 kilos, for the same indications as mentioned by Professor Eni. And they are designed for real-world administration because those small strains will support weight-based dosing, as I mentioned earlier, and definitely will ease the administration by the caregivers. And the G6PD request should be as per national protocol, national requirements. So, but just that now for children, there is a child-friendly formulation available, both on the dosing, the tablet dosing, but also the formulation. So what are the programmatic implications for successful adoption? It will require definitely the guidelines, diagnostic, the delivery, and those pediatric formulation should be readily available in the field. So for national malaria control programs, this is allowing a simplified treatment protocols because, of course, child-friendly regimens will improve health system efficiency and adherence. Update guidelines and training will be needed, definitely for front health workers to be aware and know how to use these new formulations. A plan for diagnostic and supply definitely should be in place, and then look at how to supply the testing that are going alongside those treatment, mainly for tafenoquine and primaquine. And there will be a need to engage communities, definitely, because awareness, as more awareness is out there, as much adherence and much adoption of these new innovations will be definitely done. So in general, as a roadmap, we are designing now pediatric TPPs, so defining age, weight bands, target dosage in principle, to form dosage form and acceptability before the pivotal development. To formulate, we need to formulate for real world use. So making drugs very practical with the children in mind, build child evidence early. So PKPD modeling has proven to be quite efficient in looking at what could be the optimal doses in a certain pediatric cohort. So this is something that can be used as much as possible. And then lately, having planned for access and launch, using the guidelines, the policy discussions, introduction at country level, regulatory pathways, and all the necessary path for product availability at the place where they are supposed to be used. So that for now, what I had prepared for you, and we can have a further discussion with eventually the questions and further discussions that we may have. Thank you.
Great. Thanks so much, Dr. Andre Marie. That was great. What I'm struck by is you talk about having simplified but also perhaps safer protocols for younger age groups. And I think it's also quite a hopeful sign that there is now more focus on those age groups and their biology and developing things earlier for them to increase access and safety. Both yourself and Professor Ernie spoke to research that's going on in tafenoquine. So I'm going to invite my next speaker, Dr. Briony Moore, and she's going to present some details on ongoing work that she's working on in Papua New Guinea on the pharmacology of tafenoquine in PNG. And just to note for some of the folks outside of the region, Papua New Guinea, Solomon Islands, Indonesia, the Pacific countries face a particular difficulty in terms of the Chesson strain of Vivax. And so it's quite difficult. It's quite a difficult challenge in those areas. So hopefully, Briony, you can talk a little bit to that and your work on the kids in PNG. Thanks, Millian.
So much, Carrie. I'll just share. Hopefully that's appearing okay. Fantastic. Well, once again, thank you so much. And I'm incredibly thankful for the invitation to present today and to provide an overview of a study of tafenoquine that's currently underway in Papua New Guinean children, conducted by the drug study team at the Papua New Guinea Institute of Medical Research in collaboration with our international partners. Now, I first will apologise that today I am not in a position to wow you with data. We're still recruiting into this trial, but I really wanted to provide an opportunity to give a summary of what the study is comprised of and why we're undertaking it. So just to give you a bit of background context as to what drives our antimalarial pharmacology research program. Firstly, We all recognise that children are the most biologically vulnerable population to malaria infection, but they're also often the least represented in clinical trials. And these clinical trials are integral in trying to gather evidence to guide treatment recommendations that directly apply to them. Secondary, while malaria is a global disease, its pharmacology is inherently local. Treatment responses to antimalarial drugs are shaped by a very complex interplay of parasite factors, so things such as endemicity and drug resistance patterns, host factors, which can include a patient's age, their body composition, their nutritional status, and then we've got biological variabilities as well, such as metabolic genotypes and comorbidities. And really together these factors contribute to a variability in drug exposure that can then relate to treatment successes. And this can vary quite significantly over different endemic settings. And this is precisely why we can't always just apply a one-size-fits-all to antimalarial pharmacology. And we need to potentially, or we really do need to investigate how antimalarial compounds work against a variety of settings and in a vast array of population groups. So for today, to illustrate this, I'm really going to focus on our pharmacological approaches for the treatment of Plasmodium vivax malaria. And, as we all know, this is a species that continues to challenge many of our assumptions. As we all know, to achieve what we term radical cure for vivax, we need to have treatment regimens that target both parasite reservoirs, both blood stage parasites using schizonticidal agents, as well as liver stage hypnozoites treated with aminoglycinolines. And this dual approach is really essential, not only for complete cure, but also for reducing onward transmission of vivax. So if we look at our global setting, at present chloroquine remains the recommended treatment for blood stage vivax malaria in most endemic settings. And for liver stage clearance, we really rely on primaquine and now more recently tefenoquine. And I think, really focusing in on tefenoquine, its recent approval marked an advancement in radical cure strategies, particularly forward-thinking towards malaria elimination. Unlike primaquine, from a pharmacological perspective, its long elimination half-life supports single-dose therapy, which offers a potential solution to that long-standing challenge we have with primaquine of treatment adherence. But importantly, tefenoquine also provides us a really clear example of why we can't take a uniform approach to treatment. Today, we have both adult and pediatric formulations available, which is a significant advancement, but implementation remains very complex and for a variety of different reasons. One example of this is that the World Health Organization guidance does not recommend co-administration of tefenoquine with artemisinin combination therapies, and this is due to concerns of reduced anti-relapse efficacy. So this really does present a challenge in endemic settings where ACTs are standard of care, particularly in regions with chloroquine resistance. And here we can start to see a little bit of this disconnect between pharmacological potential of drugs and real-world global applicability. And this kind of highlights this broader issue, and one that underpins much of our research program, is that whilst we continue to have remarkable advancements in antimalarial drug development, the key challenge is contextualizing these therapies, ensuring that we have the right drug at the right dose for the right patient population and in settings where burden is greatest. So what does this mean in the context of Papua New Guinea? And for those of you who are not familiar with malaria status in Papua New Guinea, it really does occupy a uniquely critical position within the global malaria landscape. It's one of the highest burden settings in the Asia-Pacific region and is also potentially one of the most complex. In Papua New Guinea, it's estimated to account for about a third of all malaria cases in the region, despite representing only 0.5% of the population in that same region. And so this disproportionate burden really reflects a convergence of epidemiological, environmental, and health system factors. And these include highly heterogeneous transmission settings, co-endemicity with Falciparum vivax, very geographically isolated populations and ongoing challenges in access to both malaria prevention and effective treatments. But importantly, Vivax plays a huge role in Papua New Guinea malaria landscape, and it's an often unrecognised contributor to the total malaria burden. It accounts for about 40% of malaria presentations that we see and frequently occurs as mixed infections with falciparum and predominantly observed as a symptomatic infection in young children. As Carrie mentioned, the tropical Chasson Vivax malaria strain, which is characterised by really rapid and frequent relapses, is heavily prevalent in PNG and really drives that sustained transmission and cumulative morbidity, particularly in the young children. Furthermore, like Indonesia, artemisinin combination therapy is first and second line treatment for all cases of uncomplicated malaria. And this is due to the removal of chloroquine from national treatment guidelines in 2010 due to established and very widespread chloroquine resistance. And then further thinking of radical cure, we have these compounding extra challenges as the prevalence of G6PD deficiency, which is both moderate and highly heterogeneous across the country. In highland populations, we have negligible prevalence of G6PD deficiency, whilst in coastal communities, it ranges between 5 to 10%, but in some specific communities, it can exceed 50% G6PD deficient prevalence, which is very high. So at this intersection of high disease burden, as well as this biological complexity of Vivax and population variability, Papua New Guinea is a critical and very informative setting for advancing antimalarial pharmacology and treatment strategies. So this really leads us to our investigations of tefenequine and looking at it as a possible antimalarial therapy for implementation into Papua New Guinea. And really those immediate questions that came to mind when thinking about how do we go about investigating tefenequine is, well, firstly, can we safely and effectively administer tefenequine with artemethyl lumefantrine or dihydroartemisinin piperacin, our first and second line therapies? Secondly, is the recommended dose sufficient to clear tropical strain Vivax hypnozoites, which we know are renowned for being somewhat primaquine tolerant and requiring higher milligram per kilogram doses? Does co-administration with fat, which is recommended with artemethyl lumefantrine, result in an altered bioavailability for tefenequine? And then is the drug actually tolerated by children, especially considering that quite often pediatric formulations are not widely available across the country, hence adult tablets often have to be split and crushed for administration. And so that really leads us into the study that I'll give you an overview of. So the tefenequine in kids study, as we regarded in the drug study team, was designed as a two-part randomised open-label study which evaluates the pharmacokinetics of tefenequine in healthy children, which is our study 1, and then the pharmacokinetic safety and pilot efficacy in children with uncomplicated malaria in study 2. So overall, we're recruiting 90 children aged between 2 and 12 years into the study from the Alexis Arfin Health Centre, which is the main healthcare facility in about 100 kilometre square area north of the town of Madang in northeast Papua New Guinea, where both falciparum and Vivax malaria are endemic, and we have large numbers of cases presenting. The primary objective of the study was to really characterise the pharmacokinetic profile of tefenequine as well as its primary metabolite in the Papua New Guinean children. And then we have a series of secondary outcomes related to safety, tolerability and pilot efficacy. Now, before I go any further, I just want to acknowledge the wonderful drug study team working in the Papua New Guinea Institute of Medical Research. And it's due to their dedication and hard work that I'm able to present any data to you today. And they really are the heroes in this research trial. So if we look at this first study where we're looking at the pharmacokinetics in healthy children, one of the main reasons that we first select our healthy cohort is that we want to investigate the pharmacology of tefenequine as well as its safety independent of malaria infection, so that we're really able to establish what drug influences there might be, but within the population of choice where we want to further then investigate with malaria. So for this study, the inclusion criteria, we sought children from the Alexisartan community who were between the ages of 5 to 12 years. They were enrolled in following informed consent procedures if they were healthy, hadn't received any antimalarial treatment in the previous month, and had normal G6PD enzyme activity as determined by SD biosensor. Participants were then allocated 1-to-1 to either Group A, whereby a single dose of tefenequine given as 10 milligram per kilogram was given with water and a low-fat meal. So this was our fasting group, and that low-fat meal was 3 plain cracker biscuits, so about a 2% fat composition. Or they were randomised to Group B, which is our fed group, where single-dose tefenequine, again given as 10 milligram per kilogram, was taken with a Tetra Pak of chocolate-flavoured milk, about a 9% fat contribution, and the low-fat meal. So the food was taken with both regimens to attenuate any gastrointestinal adverse effects that are related to taking tefenequine on an empty stomach. And throughout these studies, adult tablet formulations from 60° Pharma were used. So after calculating the required dose, so based on a weight-based table, combinations of either full or half tablets were swallowed whole or crushed lightly for administration. So to run you through the procedure, and I'm going to do this very quickly, but as you can see by this table, we have a very comprehensive degree of different evaluations to make sure that we're evaluating safety, tolerability, pharmacokinetics, as well as baseline features. So just briefly, after recruitment, we collected our baseline demographic details as well as a detailed clinical history. All participants then went full clinical evaluation, which documented weight, height, temperature, heart respiration rate, etc. We measured methemoglobin level using pulse oximetry. We did a 12-lead electrocardiogram, as well as evaluation of urine sample through dipstick and urinalysis, as well as evaluation for a Hillman score. As soon as all of these baseline evaluations were done, participants were admitted to the health centre for the first 24 to 48 hours of the study, which allowed us to really have close monitoring and allow for frequent sampling. And so we put in an indwelling cannula in order to minimise pain of frequent venipuncture, because as you will see, there is quite frequent pharmacokinetic sampling schedule. And then we drew a blood sample in order to look at our baseline evaluations across the board, as well as having a sample for future CYP2D6 genotyping. So for pharmacokinetic analysis, 1 ml venous blood samples were collected across the time points shown here. It was via the sampling cannula within the first 48 hours. And then after discharge, we took finger prick samples. At each sampling time point, we also prepared dry blood spots on Whatman protein 903 cards for blood spot analysis. And then standardised review was done just to make sure that our children were progressing well throughout the study, here focusing on haemoglobin, methemoglobin and blood smears and microscopy, as well as safety testing done throughout. A split dose adult dose was used in the study. We also did a taste questionnaire whereby children were asked to give their opinion of what the medication was like compared to a variety of other substances such as water, eating chocolate, taking artemethyl-lumefantrine, by pointing to a facial expression on this chart. And to be honest, this was a very popular procedure within the study. So just to give a bit of a summary, we recruited 30 children between October 2025 and February 2026 who were randomised into the 2 arms. All children attended scheduled follow-up time points until day 28. However, unfortunately, as many of the later time points appeared over the Christmas period, we did lose a total of 7 participants, across both Group A and B to follow up between day 28 and 56. So in the end, we have complete results from 12 children in Group A and 11 in Group B. What was very heartening is the fact that we had no vomiting after treatment, despite many children having split doses, and no severe adverse events were reported, and adverse events related to hemolysis or hemoglobinemia were also not reported. We've shipped these samples here to Perth, where analysis is scheduled for September. So our expected outcomes is really all central around this description of the pharmacokinetic profile of tafenoquine in children. For the second study, here we're looking at uncomplicated malaria and for treatment. So children aged 2 to 12 years, again, normal G6PD activity, but this time we need to have RDT or microscopically confirmed malaria. For this treatment, we are allocating or randomising children 1-to-1 to either receive their tafenoquine dose with artemether lumefantrine in group 1 or group A and dihydroartemisinin and piperaquine in group B. Both treatments will be given with water and again with food to attenuate gastrointestinal effects. Again, for the procedures, these are very similar to what we saw in the first study, comprehensively looking at baseline evaluations, as well as standardised review, safety evaluations, and pharmacokinetic sampling. The only difference in this study is that for pharmacokinetic sampling, no cannula will be inserted. We'll only do finger prick sampling for both plasma and dry blood spot analysis, and participants will be randomised into collection schedules where 6 time points out of 15 will be collected and a population pharmacokinetic model applied. On day 6, so this is if a child presents with malaria-like symptoms, we'll also collect sampling in order to confirm malaria and drug analyses at these time points. So currently we're hoping to start recruitment in June of this year, as soon as we receive our supply of dihydroartemisinin and piperaquine, and we hope to have recruitment finalised by October, November, with the pharmacokinetic analyses tentatively scheduled for April 2027. So again, here we're hoping to be able to report the pharmacokinetic profile for tafenoquine, but this time in combination with artemether lumefantrine or dihydroartemisinin and piperaquine. Now, whilst we're not powered to look at efficacy, we're hoping that the pilot data may give us an indication of whether in Chesson or fast relapsing strain Vivax, tafenoquine, whilst given with ACT, is a effective potential radical cure for Papua New Guinea. And so lastly, I'd just like to acknowledge a large number of people who all contribute to undertaking these kind of research activities. Thank you so much.
Fantastic. That's great. One key thing I heard you say, Brianne, was the translation of what's coming down the pipeline into real world implementation. I think that's quite key. And I also enjoyed the cartoon for tasting. But just to mention as well that there are a number of studies looking at ACT and TQ right now, but I think yours is one of the only ones that's looking specifically at that in kids. So I think really a gap filler and possibly more needed there as well. We're just coming up to time, and I'm going to try and assemble a few of the questions in the Q&A together and put it to each of the panelists, if you're willing to stay on. And looking at both what Maxine has written and also another colleague about G6PD in hard to reach. I guess one of my key questions is thinking about children and thinking about the complexity that occurs when we introduce new tools into the health system, because as new tools emerge, naturally a treatment algorithm will become more complex, even if it's becomes safer in some ways. How do we get these tools implemented in those harder to reach or more, as Andrea Marie described them, fragile populations? And I'm just noting also Maxine Whitaker's comment on, often she notices even for referral, parents or caregivers maybe aren't given a lot of information about hydration for the child, wrapping them in light clothing, etc., if they're feverish. So a tough question to ask, but if you could just in perhaps a couple of sentences tell me, what do you think is needed to try and get these tools to children in these quite difficult, challenging environments? I might start with Professor Ernie.
Okay, thank you, Caroline. And I think the question is really applicable for the setting like in Indonesia, because we have so many diverse area and some of them are actually difficult to reach. And so learning for our experience for the, in particular, G6PD test. So first, of course, we have the evidence, we have data that, like you said, that it's safe, it can be used. So then how can we really using this good information and implement it in our setting? So what we always do is to have this quite intense discussion from the national malaria programs and the academician and the physician on the field to have their feedback on how to we can actually use this. And then for example, for the G6PD test, we actually only focusing in the site that already had the experience on using this test. Because the question is, are we going to provide this G6PD test for all over the country? Because this is another question, because of course, if we want to use the optimized dosing of Primerkin, you should provide the test, but then will it be like access in all primary healthcare that's separated in all different area in the country? That will be quite difficult to perform. So then we start step by step by providing it in an area that already have the experience on using the G6PD test. And then we are going to escalate this within time. And of course, what we also perform is we make the other books for the technical guidelines on how we can use the tests for the laboratory technician. Also, for that, I will share the experience on using the dispersible DHP, for example. Some of the doctors, they are not really knows whether on how to give, so they put the dispersible tablets in quite a lot of volume of water, and then they finish it not in one time. So they finish it like in a separate time within like 3 or 4 hours. So then this will also give the under dosage of treatment to the children. So all these practical issues is really need to be in our consideration, not only whether we are already make the recommendation like providing the pocket books and everything, but then how this can really be received and understood by the people on the field to get the expected result as we want. Thank you.
Thank you very much. Dr. Andre-Marie?
From my previous experience working with MSF in very remote areas, and I think something that is very important is being practical. So having simplified tools and so on. I'll just give you an example. I was on the field when the rapid diagnostic testing for malaria were introduced, and this really changed completely the paradigm, because not having to carry microscopes and so on everywhere. So having such tools actually makes a difference in those type of areas. So for G6PD, for example, as we get the simplified, very simplified and practical G6PD diagnosis tool, the better for those kind of areas. And of course, something that we are working now on the treatment side, something that we are working on is the single dose for treatment, single dose radical cure, because this facilitate definitely how would I say that it ensures that when you meet a patient, you have given the full dose to that patient after the diagnosis, and you get the maximum potential of the drug for that patient. When you give the first dose, you don't know if the second, the third dose will be taken at home. Sometimes in these settings where I was working, the opportunity of a meeting between a health worker and a patient was once every 3 months. So if in one encounter you can actually make the diagnosis and give a treatment that you are sure the full course is taken, the better. So we are moving, but also it needs an improvement of the health system to get the facilities as much as possible closer to the population. But this is a more bigger question. For the tools, simplified tools, single dose treatment should be the way to go.
Thank you. And Dr. Brainey, could you comment on the question?
I think the previous speakers have very eloquently sort of outlined all of these potential risks. And I guess just to reiterate that, I think, every health setting is going to be very different, but we need to have a multifaceted approach, making sure we've got the correct tools, that there's the correct education and training, not only for performing the diagnosis or treatment, but also for the maintenance of the equipment. And that tool, it's one thing to do a G6PD test, it's another thing to troubleshoot your way through a machine that's having an error message or, having short shelf life opportunities. So I think it is, sort of, as I'd mentioned in my presentation, finding those right tools, the right setting, the right doses, to make sure, and maybe not having, as much as we would like a one-size-fit-all approach, but make sure that we have, this generalized guideline, but then we take into account for each national program what are the unique needs for that setting and tailor that sort of diagnosis treatment along those lines.
Great. Thank you very much. We're a little bit over time, but I want to say thanks so much. I think that just speaks to the engagement and interest in the presentations as well. I'm sorry we didn't get to all of the questions in the Q&A, but the panelists will respond to those and we'll send the presentations and responses out on email. To wrap up, I just want to say what I've heard today is we need practical, context-specific guidelines, but also we need to bolster the health system as well as providing the simplified tools to make sure that everyone can access the simple tools and move countries towards elimination. But with that, I'll say thank you very much to everyone. Thanks so much to the participants from across the world, really, and have a great rest of the day there. Oh, there's a poll to end on, just in case. You can fill that in before you leave. Thank you.